All right, everybody. So we're going to dim the lights on this one. This one's pretty ultrasound heavy. For those of you that may not be able to see as well over here, you're welcome to come push this way. You can have my seat up here, one person at least. So originally I was going to talk about the approach to shock, undifferentiated shock patient, and had that ready to go. A lot of that is physical diagnosis stuff. A lot of that's not really new. So secretly, I kind of wanted to present this one to you and was kind of feeling it out yesterday while we were doing ultrasound, and there seemed to be a really big interest. So this is really more the cutting edge stuff in the management of the undifferentiated shock patient. So I'm thrilled to actually get to present this to you. This is how we use ultrasound to differentiate that undifferentiated shock case. Now, will you be able to walk out of here and do this algorithm as I'm going to present it to you today? Probably not. You need to get your hands on the Ultrasound Pro, but this is to inspire you, to get you to start thinking about using this. If you are coming on shift or maybe going off shift and your partner has one of these cases, drag the ultrasound machine in there while you got a little bit of time to do some scanning and you're not having to actually do the medical care. With a little bit of practice, you can do this. You do not have to be an ultrasound super user to do this, all right? So with that, I'd like to start off with a case. This is, I actually have 3 cases in here. It's going to be dependent upon what kind of time is left, what I get to show you, but all 3 of these cases are our cases from MCG. So the first one is a 55-year-old woman with a history of diabetes and end-stage renal disease. She's referred to the hospital for amputation of a gangrenous right toe. She was sent to the emergency department because they didn't have any beds upstairs. They asked if we would board her, waiting for a bed to open up. You can see her vital signs right there. Nothing terribly concerning, and to be frank, her physical exam wasn't really that concerning either. Her labs are consistent with her known pre-existing conditions, and her x-ray was not concerning, and we did what the outside provider asked us to do, which was blood cultures, antibiotics, and basically tee her up to get seen by ortho. About 5 hours into the hospital stay, the nurse let me know that the blood pressure was 80/60. Patient was sleeping but easily arousable and frankly had no complaints. Because she was an end-stage renal diseaser, we gave 1.5 liter bolus in 500 ml aliquots with really no effect on the blood pressure. I want to ask you, as I'm going through this lecture, to think in your mind what you would do in this case. And then I'll show you what actually was wrong with the patient at the end of the case. So why use ultrasound? Well, it's going to augment your clinical impression. I'm not saying replace your clinical impression. Clinical impression still reigns supreme. Ultrasound is going to augment that. It's done simultaneously with your resuscitation at the bedside. I may be doing an ultrasound and taking a history and physical at the same time. I heard somebody mention delays with, it's easier just to get a gallbladder study with a radiology suite. Well, when I get a right upper quadrant abdominal pain, I drag my ultrasound machine in there. I'm doing my history while I'm doing the ultrasound at the same time, and then do my physical exam as well, okay? So this can all be done at the same time, and it can be used to guide your resuscitation, as you will see, and the patient never leaves the safety of your care in your resuscitation. There's a whole bunch of algorithms out there. The famous one is the Rush protocol. There was ones before the Rush protocol. They all work around the same principles, okay? And that is a tank, a pump, and some pipes. For us, the tank is going to be the inferior vena cava. The pump is going to be the heart, and the pipes are going to be the large vessels of the abdomen and thorax, okay? And largely the aorta. But there can be other vessels, okay? And we'll talk about that. Why do we call the IVC a tank? Well, first we got to think about the anatomy of a vessel, of an artery and a vein. Artery is a thick-walled structure. It maintains its architecture, whether there's high pressure or low pressure, whereas a vein is a thin-walled structure that will change its architecture depending upon what the luminal pressures are. Take, for example, elevated jugular venous pressure, right? Jugular venous distension. Jugular vein, external jugular vein, is dilated because there's high luminal pressures. Caput medusa, high luminal pressures. It distends. Highly compliant vessel, okay? And then we have varicosities, varicose veins. Due to valvular insufficiency, there's high luminal pressures and they dilate. It's the same principle with the vena cava. The systemic veins harbor about 60% of our circulating volume, and a good chunk of that is in the vena cava. Okay? And for us specifically, the inferior vena cava, and it's no different from any other vein that I was just showing. It's a highly compliant vessel and will change diameter depending upon what the luminal pressures are. How do we identify it? Well, we did a little bit of this yesterday. For me personally, I start off with the probe indicator pointing to the patient's head. And I'm going to, again, kind of skip through a lot of this. Hopefully you understand what the probe indicator is. That's the green dot right here. It's pointing to the patient's head. That green dot correlates with that GE. So the patient's head is on this side of the screen, and the feet are down on this side of the screen. So we are effectively doing a sagittal cut through the liver. Now I start in the middle and just slightly tip the probe to face the patient's right side, and that will bring the inferior vena cava into your view because the inferior vena cava lives on the right side, the aorta lives on the left side, patient's side, of course. And you'll see the inferior vena cava traversing through the liver up to the right atrium. And you can see as that patient breathes in, generating negative intrathoracic pressure, it's pulling blood up to the chest, specifically the right atrium. And it's like imagining if you were sucking on a straw and you capped the end of it, right? And you pulled and it would collapse in the middle, okay? Alternative way you can do this, some people teach it this way, do a subcostal view of the heart. Some people are very comfortable with this. You see the right atrium. You're just going to stand the probe up and you're going to convert to your inferior vena cava, because by standing it up, you're shining down into the abdomen to see the inferior vena cava. And then you just turn long axis. So by rotating the probe indicator back to the head to get where I just showed you a second ago. And there's your vena cava again. Okay? Now sometimes you're going to misidentify the aorta as the inferior vena cava. There's two key structures on the aorta that will help differentiate that, and that is the celiac trunk and the superior mesenteric artery. Also, if you look very carefully, you see that the aorta is diving behind the liver, not through the liver like the vena cava does. Here is the vena cava again. Here's liver on both sides. We also see here very nicely a very large hepatic vein, and I use that image just to accentuate that. They don't always look this big. But if you look very carefully, you'll see a little notch in the proximal IVC, and that's where the hepatic veins enter into the vena cava. So that'll help you differentiate the two. So that's the IVC, and that is the aorta. Now, how do we interpret the IVC as full or empty? Well, let's take a look right here. Here's our inferior vena cava, and you can see as that patient breathes in, how do we know they're breathing in? You can see it descends to the right-hand side of the screen, the liver does. Here's the liver, it descends to the right-hand side of the screen. That's the diaphragm pushing it down as they breathe in. Remember, the head's here, the feet are here. And we see that inferior vena cava collapse in on itself. This would be a low tank. There's another one. Inferior vena cava right here. This patient, finally takes a breath. There we go. All right. Very low intraluminal pressures. And this one, if you're not looking carefully, you'll miss it. There's the vena cava right there. Very small, low tank. What do we know just from this image? Imagine that patient sitting before you. Blood pressure is 80 systolic, diaphoretic. You can't get any history out of them. You put the probe on there. What do you get just from this image? We know that the differential diagnoses that lead to hypovolemia are much higher on our list. We know things that cause high right heart pressures like pulmonary embolus, tamponade, tension pneumothorax, and pump failure are less likely. In fact, I'd say they're off the list. We also know, just from that image, this patient needs a large volume resuscitation. So we're not doing 500 ml aliquots just from this image. We're saying 3 liters of crystalloid. And we're going to keep looking in the back of our mind, using our clinical integration, this patient may need blood if we find a hemorrhage somewhere. Okay? Now, alternatively, how about a full tank? Here's our IVC again, traversing through the liver. As a patient breathes, you see it descend or migrate across to the right-hand side of the screen. Really no variation in that diameter. Now, where are we looking for a diameter change? We're looking about 2 to 3 centimeters proximal, because we're talking veins, 2 to 3 centimeters proximal to where the IVC enters the right atrium. So we're looking about right here. All right? And the reason that's important is because if you look right here, the diaphragm oftentimes will tether open the IVC, so it's a less reliable place to look. And if you start getting further down towards the feet, the IVC is also very highly compliant. You have the liver that's pressing on it. And not lastly, and probably most importantly, most of the studies looking at this are looking right here. So that just goes with all the other studies. Okay? Here's another one. So our hepatic vein coming in. IVC here, we can see right atrium right here. Not a lot of diameter variability. And one more. This one has, I don't know, 5–10% collapse. If you look very, very carefully. Doesn't really matter what percent collapse, right? It's large, all right? Minimal diameter change. What do we know from this image? Things that cause elevated right heart pressures are much more likely. Pulmonary embolus, tamponade, tension pneumothorax, pump failure. Less likely, although not off the list, is hypovolemia, and I'll explain that in a minute. We also know large empiric volume loading may not be the best thing for this patient. So we may start off with a 500 ml aliquot bolus, see what their blood pressure does, and continue our algorithm, continue gathering some clinical information to try to figure out what's going on with this patient. Now you're going to see this from time to time. In fact, those of you that scanned with me yesterday over in the room there, we saw this on our model. Pretty highly compliant. I don't know, this is probably about 50%, 60%. Notice I'm not taking measurements, I'm just eyeballing this, and that's all I would ever expect anybody to do. It's very simple. We're not taking measurements with a spontaneously breathing patient. These are all spontaneously breathing patients, by the way. Let's take a step back, and let's really get to the bottom of what the IVC is telling you. The way that I like to do this and try to illustrate this is imagine a river that's meandering along. It's contained within its margins, within its shoreline. It's a normal river. But the next day you come back to that river and now it's flooded and there's water out past the margins. There could be a few reasons this happens. Maybe there was a big rainstorm overnight. Maybe they opened the floodgates on the dam, putting more water in the river. Maybe that dam busted. Now there's more water coming downstream and it flooded. But it could also be that they have put a dam downstream, okay? And really at the end of the day, that's what you have to remember, okay? The IVC is not truly a marker of volume, it's a marker of pressure in the right atrium, okay? So it's a surrogate of volume. So this is a big limitation, and this is why I was saying just a second ago, we can't rule out hypovolemia 100% by a large plethoric IVC, because it could be that they just have a bad right heart, and that's what their IVC looks like all the time. They could have pulmonary hypertension. That's what their IVC looks like all the time. So, take home point, the IVC is not the be-all, end-all when it comes to volume assessment, but definitely not useless either. Okay? So, it has to be used within the clinical context. We were scanning yesterday, saw a highly compliant IVC, very thin. This is a person who is clearly not in shock and has, frankly, no complaints. So you're going to see highly compliant IVCs. If that patient is well and they have normal blood pressure, they're not clearly in shock, you do not have to give them a fluid bolus. All right? So always remember that. Again, I will say clinical context reigns supreme. Now let's change gears just a bit. What about the intubated patient? So far we've talked about the patient who's spontaneously breathing. Actually, the IVC diameter in the intubated patient is probably the best studied modality for the inferior vena cava. And here it's going to effectively be the reverse. When we take a breath in as we're all doing negative pressure ventilation sitting here in this room, our IVC is collapsing. When we use a ventilator to use positive pressure ventilation, we create a pressure head and the IVC dilates with delivery of that. Deliver that breath, right? So here's end exhalation, 2.09 centimeters. We gave a breath and it dilated at 2.37 centimeters. If it's much greater than 15% dilation, then you can feel pretty comfortable that that patient is going to be fluid responsive, okay? With all these other, by the way, we were talking about really more fluid tolerance. Let me take a step back. It's not been well studied, actually, it's not been well studied. we've not been able to clearly establish what diameter or if a diameter, what percent diameter collapse correlates with fluid responsiveness. We give a fluid bolus, cardiac output increases. That's never really been parsed out in the literature on a spontaneously breathing patient. However, fluid tolerance is pretty well studied, i.e. we're going to give a fluid bolus and we're not going to hurt the patient. Some people often cite 50%. I like to go to about 30%. Okay? And this is just based over tons and tons of studies of the IVC. Patients do just fine if you keep going up to about 30%. Now, back to the intubated patient. Again, you have to actually measure that. And again, we're measuring about 2 to 3 centimeters proximal to the right atrium. Because the diameter change is so small, you actually have to measure it. You can do a Cine loop on your computer, freeze, and scroll through and make your measurements. It's not as hard as it sounds. So it still has, and my experience has been in the emergency department, in the acute phase of resuscitation, a lot of times their IVC is still really small because we haven't done a whole lot of resuscitation, even though they're on the ventilator. All right? Now, that's the IVC. Do we have any questions on the IVC? All right, so now we're going to move on to the pump, to the heart, okay? And we're asking 3 simple questions. We're not cardiologists here. We're not trying to replace the cardiologist. We're asking 3 very simple questions. Is there fluid around the heart? Are the ventricles proportional? And is the ejection fraction normal? Now, there's multiple windows, lots of windows that you can use to evaluate the heart. I recommend using at least 2, really more 3 windows, because not everybody has all those windows. Everybody's body shape is a little different. Some people aren't going to have a subcostal window, and you're going to have to use a parasternal. Some people aren't going to have a parasternal. You're going to have to use an apical. So I recommend using at least 3 windows. It's personal preference. If you really, the heart is probably the most challenging orientation, challenging application of ultrasound to understand from an orientation perspective. I'm not going to spend a ton of time talking about that other than just to kind of illustrate a couple of windows. This is what we call the parasternal window, and we're basically cutting the heart in long axis. You can see how the heart is laying in the chest. We basically put the probe parallel to the long axis. And if you look down the barrel of the heart, you can see we're cutting through just a bit of the right ventricle, which is right here, and then the rest is all left ventricle. This is what it looks like when you get a nice parasternal view. Right ventricle, really more the right ventricular outflow tract, so just a small portion. Then you get pretty much the whole left ventricle minus the apex. A lot of times you're going to miss the apex in this window. Here's the left atrium. Here's the aortic outflow tract. Here is the aortic valve. So blood is coming like this and out, right? In, out, in, out. Apical window, now we've just moved the probe out below the left nipple to look down the barrel of the chambers, and we're cutting the heart this way. Here's the right ventricle, left atrium, right atrium. And this is what it looks like. Here's a subcostal window. A lot of folks know the subcostal window. We're just basically looking through the liver. The liver is your acoustic window to look through, and then you're going to see the first chamber that you're going to see is the right ventricle, right atrium, and then obviously deep to that, as you can see right here, deep to that is the left ventricle, left atrium. All right, so here's a subcostal 4 chamber. All right, we have on our website a video that I did for our medical students, but it's not just for medical students. Is about a 20-minute video on really how to do the orientation for echocardiography, and try to go into it as much detail as humanly possible and try to clear some of that stuff up. So that is on there, and also it'll be on our YouTube page as well. But EUS Academy, and then if you click on Ultrasound Medical Student Education, there's this video as well as a host of other videos. So let's go back to our 3 essential questions. Is there fluid around the heart? Well, where is the pericardium? Here's the pericardium right here. All right, and we're looking for a black stripe there. See, black inside the LV. That's where it's supposed to be. We're looking for anything black outside the myocardium, but contained within the pericardium. So this is a negative study. How about this one? That's a positive study. This is a pericardial effusion. Now, there's one key thing here I want you to see. You see the descending thoracic aorta right here. I didn't point that earlier, but that's what that is. Let me back up again and activate that one. Here we go. Descending thoracic aorta. That fluid is dissecting between the left atrium and the descending thoracic aorta. That is 100% a pericardial effusion, as opposed to another image I'll show you in a moment. What about this one? Pericardial effusion or not? This is a subcostal window. Just think to yourself. You don't have to ask it out or answer it out. That patient has no pericardial effusion. Here's your pericardium. On the posterior aspect, here's the anterior aspect, no pericardial effusion. Whereas here's another subcostal window. Very easily you can see there is fluid around the heart, and this is actually a pericardial effusion. With the subcostal window, I caution you just a little bit, left-sided pleural effusions can look like a pericardial effusion. All right, I've seen patients go for emergent thoracotomy in the trauma setting when they just had a hemothorax. All right, so you've got to be a little bit careful with that subcostal window. Here is how you will differentiate the two. Here's our descending thoracic aorta. You'll see that there's really no fluid. You can make an argument there's a thin little stripe right here, maybe a trivial pericardial effusion, but this is probably what's getting your attention. Notice how it goes posterior to the descending thoracic aorta. That's a pleural effusion. This is not a pericardial effusion. Here's the pericardial effusion again. Now, we found pericardial effusion, but is that tamponade? Does that mean it's tamponade? What in the world are we going to do with this? Well, identification of tamponade by echocardiography can be quite challenging. One of the first things that you'll see is a collapsing right atrium. Okay? Now, that one looks really easy, but they're not always that easy. How about this one? This is a parasternal long axis view. You look right here on the free wall of the right ventricle. It's collapsing in. All right, Dr. Fox out in California made this famous by calling this it looks like a man jumping on a trampoline. Okay, that's actually tamponade. Now, here's a parasternal long axis view. It's reversed, so forgive me for that. But I want you to look right here. Is this tamponade or not? This is a patient who was stabbed in the chest. We're looking right here. It looks good, looks good. I don't think it's tamponade, right? Well, wait, what's that? It is tamponade. And it's by respiratory variation. So why do I put this up here? I put this up there because I want to illustrate you how misleading it can be trying to do echocardiography for tamponade. It can be quite challenging. I want to submit to you there's an easier way. Now this one obviously, nobody's going to miss that. You see the RV is completely obliterated. It's not even expanding. All right? So I want you first off to resist the temptation to call this tamponade just because of the size of the pericardial effusion. Let's have a look at this one right here. And then I'm going to tell you how I like to use ultrasound to differentiate. We see here a subcostal window. There is a pericardial effusion. It's circumferential. We just went out a plane, but it's circumferential. To take my word on that. Now, looking at this, you may think this is tamponade. This is clearly tamponade. Here's the inferior vena cava. Highly collapsing. In fact, I'll say it's 100% collapsing. This patient does not have tamponade. All right, it's be the first tamponade that's ever been found that has low right heart filling pressures. All right, this patient doesn't have tamponade. Alternatively, if you see that with this, I would treat it as tamponade. I believe in keeping this as simple as humanly possible. All right. In the end, will it 100% be tamponade? Maybe not. But every case of tamponade I've seen, they've had an IVC that looks like this. So treat it as tamponade. If they are stable, if you have a person in your center who can come in and do the pericardiocentesis, that's what you should do. If you need to get them out, that's what you should do. If they are unstable, you have to drain that patient. And I would use ultrasound guidance to do that. But you have to do it. You have to do it. I would feel very comfortable doing this if I had an unstable patient with a pericardial effusion of any size who has a large IVC. Now, if you got a little tiny pericardial effusion, I don't know, it might be a little bit challenging. If it's trauma, that's another debate. Let's not worry about that. I mean, trauma, they probably need a thoracotomy, let's face it. I would treat it as tamponade. All right, use your IVC to differentiate between tamponade or no tamponade. Now, question 2, are the chambers proportional? The normal left ventricle the normal right ventricle is about half the size of the normal left ventricle. So this is normal. Right ventricle, half the size of the left ventricle. All right. Compare that with this one. Right ventricle, left ventricle. This patient just came from a cross-country trip and got out of the car and had sudden onset of shortness of breath and chest pain. All right? The pain's in their chest and in their back. Probably a PE, but they're saying, oh, it's really in my back too. It could be a dissection. I'm getting really uncomfortable. I really want to lyse this person. I feel really good about it if I see this on there. Okay? This one's tough. This one's a tough one. This is one I saw a year and a half, 2 years ago. This right ventricle here is about the same size as the left ventricle. I put this one in here to show that it's not always as clear as what I just showed you. Now, the image quality on this one is quite poor, especially with it being projected. So this particular machine was acting up a little bit. Here's another one. Right ventricle is larger than the left ventricle. And remember, we're looking at the chamber size. We're not looking at the muscle itself. We're looking at the chamber size. Also a very large right atrium as well. So, right ventricular size equal to or larger than the LV. Very concerning for pulmonary embolus. Now, ejection fraction. Is ejection fraction normal? Well, first off, as emergency physicians, can we determine ejection fraction? This is one of those studies that's a little bit frustrating, where we use the cardiologist as the gold standard. And basically what they were doing was comparing eyeball assessment, which I'm going to teach you how to do, and you're going to see you can do it yourself here in just a second. We're doing eyeball assessments of ejection fraction, and basically there was 86% overall agreement, but the sections where we did the best was normal and poor. And I would submit to you, that's what we care the most about. If they have a mildly reduced ejection fraction or a moderately reduced ejection fraction, it's probably not going to help us as acute care providers. We really care about that poor group, and we care about the normal or hyperdynamic group. Here's a study that was done in peds, similar agreement, 84% overall, and it was an eyeball assessment. So, and again, the two categories that we did the best in was normal and severely depressed. Again, this is all assuming that the cardiologists are really good at doing this themselves. So it's one limitation to that study. What I would submit to you is don't use percentages. Just say normal, or severely reduced, or hyperdynamic. Don't put percentages, because the percentages are going to change based on your management a lot of times. Okay, they'll go from hyperdynamic to normal when you give them fluid boluses. If you give them inotropes, they may go from normal to moderately or mildly reduced. All right, so just put just assign a kind of a qualitative assessment, not a quantitative assessment. Now, how do we do this? How do we do the eyeball method? Well, again, here's the left ventricle, and we're just looking at the difference in the diameter, the volume of the chamber between systole and diastole. Okay, so diastole, systole, diastole, systole. And we're going to, in our minds, use our mind's eye to look at the difference in the volume of those two chambers. Okay, remember, this is a 2D representation of a 3D structure. And that's roughly a 50% change. So that would be a normal ejection fraction. Compare that one with this one. Normal or abnormal. You don't have to answer that, but just think to yourself, normal or abnormal. It's actually a reduced ejection fraction. It's probably a moderate to severely reduced ejection fraction. Compare that with this one. Here's the left ventricle right here. Normal or abnormal. I submit to you it is abnormal, and it is a severely reduced ejection fraction. Compare that with the normal here. All right? Lastly, how about this one? Here's the LV right here. Now this is an oblique cut. This particular patient didn't have a great parasternal nor apical window. So this is kind of what I was telling you just a second ago. They're not always going to have those pristine windows, and you can't always roll the patient over like the cardiologists do to do all your echo scans. Okay? So we have to do the best we can with what we've got. This is clearly a hyperdynamic LV. All right? Now, we talked a little bit about tension pneumothorax. All right? You could see a dilated IVC, hyperdynamic LV, and that could be a tension pneumothorax. You can do a rapid assessment for that with ultrasound, and I demonstrated that yesterday in the ultrasound breakout session. This patient clearly does not have a tension pneumothorax. We are done. Keep moving. That took all of 20 seconds. All right? Whereas if you have a patient who could have a tension pneumothorax, the clinical picture fits, and you see this, that's the side you want to needle, the right side. Okay? No sliding lung. Does that 100% rule it in? No. Remember, air collects anteriorly. If you come around this side here, you can see where the lung and the pleura are still intact. This is where the lung point is. You see how you have some slide here, but no slide here. Here, the visceral and parietal pleura are still intact, whereas here, it's just the parietal pleura. This is 100% specific for a pneumothorax. Now, remember, if it's a tension pneumothorax, everything is going to be peeled away, so you won't find this. Okay? So if the patient is truly unstable and you're considering this diagnosis, you're probably not going to have time to go hunting for a lung point as you scan around the side of the chest. All right, if you're thinking this patient could have a tension pneumothorax and you see loss of a sliding lung sign on one side, just needle that side. All right, moving on from the pump. Let's talk about the pipes. Now, let's look at this right here. We can see clearly there's a leak. Obviously there's a leak. We don't know where it's coming from, and that's kind of what we're using ultrasound to do. All right, you have to ask yourself a couple questions. One is, does this patient have a high likelihood of having a AAA? If it's a 75-year-old male smoker who's coming in with flank pain and syncope, I say start with the aorta. Scan the aorta first. If on the other hand, it's a 24-year-old woman coming in who just missed a period and had syncope, I wouldn't even scan the aorta. I would go straight to a fast exam to look for free fluid in the belly. All right, well, if we're doing a fast exam, we walked through that a little bit yesterday for some of the folks. This is Morrison's pouch right here. And you can see nicely that the kidney and the liver are in contact with one another, whereas here you can see a black stripe that dissects between the two. That's consistent with free fluid in Morrison's pouch. In the left upper quadrant, I talked with some of the folks yesterday. The place that you're most likely to find fluid in the left upper quadrant is between the spleen and the diaphragm, and we see a large stripe of fluid here. That would be fast positive. Here's the pelvis. Here's the bladder. We're looking lateral to the bladder. And you can see here clearly contained fluid. We know it's in the area of the bladder, so this must be the urinary bladder because we're looking in the pelvis. Whereas this is free fluid. And it tends to take these sharp points because it's settling in all the nooks and crannies. And that's one of the ways you can differentiate contained fluid from free fluid. Now, with regards to the aorta, it's a very rapid evaluation. We're just going to scan down, and if we find something that looks abnormal, we're going to measure it. Remember that the aortic aneurysm tends to have a spike in annual, not a spike, an increased incidence in annual rupture rate after at 5.5 centimeters. The annual rupture rate is 3 to 15%. Remember, that doesn't mean that a 4.8 won't rupture either. So just bear that in mind. If you ever find one that's sub 5.5, you can still treat it as a ruptured AAA. I'd still get the vascular surgeon involved, transfer them out, treat them as a ruptured AAA. All right. How do we do it? We start up high in the epigastrum and identify the aorta. The key landmark here is the spine. This is the spine here, and then I'll point out the aorta, but let's keep following. The aorta becomes more superficial the further we go down, and then at the level of the umbilicus, it bifurcates. Now, as this thing recycles, I will show you actually the aorta. Again, first thing that we're going to do is identify the spine. This is the spine here. Here is the aorta, because it sits on the patient's left side. There's the aorta. It's coming down, bifurcation right there into the iliacs. I don't know how long that took, 8 seconds, 10 seconds, something like that. Normal caliber all the way down. You just took AAA off the table, keep moving. Up on the other hand, you see this. You got a problem, okay? This is a aortic aneurysm, and this is a true lumen. This is all mural thrombus here, and then you've got a little bit of blood that's still collected here. Now, if you ever see this in a patient who is coming in shock, even though you're not going to see free fluid, remember, it's a retroperitoneal structure. Ultrasound cannot identify retroperitoneal free fluid. You treat it as a ruptured AAA. Okay? You treat it as a ruptured AAA. Now, you can do your measurements. You can go back and take a more careful assessment to see if it's infrarenal or suprarenal. and you can pass this on to the vascular surgeon. But you see this in a patient who has shock, even though there's no free fluid or retroperitoneal fluid, it's ruptured AAA until proven otherwise. Get the vascular surgeon involved. All right, now let's go back to our case. If you guys recall, this was an end-stage renal disease patient who has a history of diabetes. She was coming in and a bed hold to get a toe amputation the next day, and she became hypotensive and unresponsive to our fluid. So here is her IVC. What do you guys think? It's large, right? High right atrial filling pressures. So for me, in my mind, I'm going to take a look at the pump because there might be a problem up around the pump. All right. This patient has a large circumferential pericardial effusion with a dilated IVC. I'm going to treat this as tamponade. Now, the patient was mentating well, so I went ahead and gave the cardiologist a call. They came in, took a look at it, and said, yeah, they do some more complicated measurement. They look at mitral valve inflow velocities, and they can see variability with respiration, much more complicated assessments. They said, yes, this is tamponade. They took her straight to get fluoroscopic guided pericardiocentesis. So imagine that. A patient comes in for toe amputation, and she's got pericardial tamponade. Real case. I don't know how in the world we would have made that diagnosis otherwise. I think we're supposed to be on break right now. Okay, for those of you that want to stay and see two more cases, you're welcome to. For those of you that want to go on out and get something to eat or drink or whatever, your call. Whatever you want to do. I'm not going to be offended if people want to start moseying out. All right. Here's a second case. This is a 58-year-old man with no known medical problems. Was in the right upper quadrant, abdominal pain. It was sudden onset, sharp, radiating around the right chest. It woke him from sleep. Never experienced this pain before and states it hurts to breathe. He has no other associated symptoms. He has some very concerning vital signs. Blood pressure is 90/60 with a heart rate of 122. Temperature is 38.0. All right. Physical exam, the patient is pale in appearance, is tachypnic and exquisitely tender in the right upper quadrant to deep palpation, and that recreates the exact pain that this patient is complaining of. Our initial concern was sepsis secondary to cholecystitis, so we did an ultrasound evaluation for cholecystitis, and while we were doing that, we saw this right here. Okay, very large IVC with minimal diameter change. We flip up to take a look at the heart. This is the liver here. Here is the right ventricle and right atrium here. And I want you to look right here very carefully. That's the chamber of the LV. The rest of that's muscle. So you can see that the right heart is much larger than the left heart. This patient had a saddle embolus with right pulmonary infarct. So that's where the pain was coming from. All right. So this patient got lysed and unfortunately died on hospital day 3. But ultrasound gave this patient the best chance for survival. I don't think we would have been able to make as quick of a diagnosis without ultrasound in that case. Would have felt very uncomfortable lysing that potential gallbladder, right, for PE. Well, I don't know if we would have 100% thought the diagnosis, to be frank with you. Case 3. This is a 65-year-old woman with a history of cervical cancer, end-stage renal disease, hypertension, good compliance with dialysis regimen. Family report, she's not been herself for the last day. She has poor PO intake, and she really can provide no further history secondary to her condition. Her vital signs, as you can see, are quite concerning at 74/45, tachycardic at 140, and she is hypothermic and she's hypoxic. Her exam is consistent with pneumonia and shock. Okay, and her x-ray shows a pneumonia as well. She has a lactic acidosis, and we went ahead and started appropriate treatment. We gave her 2 liters of fluid over 30 minutes, and her blood pressure remained low at 80/50. Resident was concerned about giving her more fluids because she's an end-stage renal disease person. We don't want to put a dialysis person in volume overload. So we brought ultrasound in. Here is her vena cava right here after 2 liters. She can tolerate more. She can tolerate more. It's near 100% collapse. We went ahead and did our other stuff because she's a 72-year-old lady and she could have other things going on. So we checked her aorta. It was normal. We did a fast exam. That was normal. So I put all of that to rest and continued down our sepsis treatment. So after an additional 2 liters, here's her IVC. She was making some improvement, but not where I wanted her to be from a mentation perspective. So she's, 40%, 50% collapse, something like that. So I went ahead and gave her 1 additional liter, and her blood pressure ultimately stabilized at 115/75, and her lactic acid cleared. Mental status was much better. Here is presentation. This is actually, you've seen this image a couple times, this is actually that patient. Hyperdynamic LV. IVC right here looks like a slit. Whereas here, after 5 liters, that LV looks much more happy. And then IVC at end inhalation looks a lot better. All right? So the patient ultimately got admitted to the hospital floor and was discharged after 4 days. Yeah, after 4 days. Final diagnosis was severe sepsis secondary to pneumonia. So we saved this patient an ICU admission. And who knows, with the aggressive care that we felt comfortable doing with ultrasound, maybe we saved her life. I don't know. Can't prove that. So anyway, hopefully this illustrates to you the utility of ultrasound. Hopefully inspires you to start using it yourself at your institution and maybe doing a little bit of listening to some podcasts or coming and scanning with us sometime, whatever you want to do. All right, any questions?